Good afternoon, Honorable Chair, everyone present here. Sorry for the technical delays. I am Sita Shomenali in front of you all, and I would like to present today on the topic Urban Health and Equity in Nepal, Analyzing Social Determinants, Disease Prevalence, and Health Outcomes. Before beginning this presentation, I would like to thank the organizing committee for bringing us all together for this important summit. And I would also want to acknowledge my study team for their contribution to this study. Urban Health Equity in Nepal, Analyzing Social Determinants, Disease Prevalence, and Health Outcome is a part of our broader work under the Project Chorus. This is the outline of today's presentation. Talking about urbanization and equity concerns, we all know that Nepal is facing rapid urbanization in Nepal, and it is drivers that urban population in Nepal are facing well-developed infrastructures, access to essential services, technological advancement, and better environment. Talking about the background, there is rapid urbanization in recent decades in Nepal, with 66% of population living in urban areas projected to rise further, which takes us to inequities in healthcare, education, clean water, and various lacking opportunities. These all are the factors which leads us to socioeconomic determinants, overcrowding, limited healthcare access, and higher disease burden, which leads to dual burden of disease. Now, urban areas are facing both communicable and non-communicable diseases. The main objective of this study is to examine and compare the social determinants, health indicators, and disease burden across different municipalities, municipality types, urban areas, and poverty statuses in Nepal. We did a secondary data analysis and used all the 4 national reports, namely Nepal Demographic Health Survey, Nepal Housing Population Census, Nepal Living Standard Survey, STEP Survey. The data on social determinants, disease prevalence, and maternal child health outcomes were compiled into from the 4 national reports were compiled, and then cross-tabulation was done to compare between rural and urban areas, as well as Kathmandu Valley and other regions. Urbanization in Nepal, expansion to explosion. As we all know, urban areas continue to grow rapidly in Nepal. We can see both opportunities and challenges at the same time. Urban centers are now, from 1952, there were 10 urban areas, and now it has exploded to 293 in 2021 after federalism. We can see 66% of the urban population, 300% growth in urban population and household in just a decade. Urbanization and social stratification. This table highlights the social stratification across different residence types in Nepal. As we move from rural regions to the metropolitan to the urban areas, we can see a better literacy rate, ownership of household assets, improved sanitation facility, improved drinking water, use of electricity, and better clean cooking fuel. But we can see that active employment rate in rural areas is higher than urban municipality with 47.3%. Urban poverty, demographic, and provincial outlook. We can see that 58.9% of the population residing in the urban regions are poor. 66.5% of the people residing in the urban regions fall in the poor distribution. 56.7% of the urban poor are literate, while only 26.8% of them are employed. We can see the provincial bar here, where higher concentration of urban population are found in Madhya province, followed by Lumbini, Koshi, and Sudir Paschim. Urban clusters witnessing NCD prevalence. We can see that urban regions, particularly Kathmandu Valley, have higher prevalence of diabetes at 22.4% and heart condition at 5.8%. By wealth quintile, we can see that the richest group have the highest rates of diabetes at 14.7% and heart condition at 8%. On the right, we can see that NCD risk factors are significantly higher in the urban poor, while 26.9% have hypertension, and the urban poor are facing NCD risk behaviors. High disease burden and mortality in the urban clusters. we can see that there is a high burden of NCD and CDs among the females. Urban areas outside Kathmandu Valley report higher rates for communicable disease. Highest burden of NCDs were by blood pressure in male and gastrointestinal disease in female poor. We can see that better outcomes in some of the indicators in the rural areas. 82.4% of the rural women attend 4 or more ANC visits compared to 79.5% in the rural areas, and 80.3% of the rural children aged 12 to 23 months are fully vaccinated compared to 79.8% in the urban areas. Across wealth quintile, we can see that the highest wealth quintile has the best outcomes with 92.6% attending ANC visits. Stunting in children under 5 is higher in rural areas at 31%. We can see that in Kathmandu Valley, 34.9% prefer pharmacy for communicable disease compared to 40.2% in the urban settlements. For NCD, private hospitals are highly favored in Kathmandu Valley. To conclude, this study reveals significant disparities in health and socio-economic indicators across Nepal. Literacy, maternal and child health services, and NCD prevalence vary widely between metropolitan cities, sub-metropolitan cities, and rural areas. Urban areas have greater access to healthcare services. Rural areas face elevated rates of hypertension, limited access to maternal health services. So these findings underscores necessity of context-specific policies and strategies, resource allocation to address distinct health and socioeconomic challenges. The takeaway message, to really close these inequity gaps, we first need to identify and prioritize addressing systemic and preventable health inequities linked to social, economic, and environmental structures. Then, secondly, assess disparities in health outcomes that disproportionately affect marginalized people. Third, by ensuring that outcomes are clearly identified to target modifiable factors influencing health inequities. And finally, by enhancing the data collection systems to include equity variables, enabling the measurement and monitoring of progress, closing health inequity gaps. Thank you.